I'll be speaking to you mainly on specifically on the management of severe malaria. Just to comment on the distribution of vivax and falciparum malaria. The traditional thinking is that severe malaria occurs only with falciparum malaria. Worldwide, falciparum malaria accounts for 60% of all cases of malaria. 40% are vivax. A lot of data comes from Africa on falciparum malaria, and the reason is in Africa, vivax malaria is very rare. It's supposed to be less than 2 or 3%. So more than 95% of malaria in Africa is falciparum. In contrast, the situation in India, about 25 years back, 95% vivax and 5% falciparum. We now have data from the government for the year 2007, and the proportion of falciparum infections has now increased to 40 to 50%. So we can see that in India there is a gradual change in the epidemiology. There are more and more cases of falciparum malaria, proportions of falciparum malaria that we see. This is a typical patient with severe malaria. 40-year-old lady came with 8 days of fever, jaundice since 3 days, oliguria since the last 1 day. On examination, there were no subconjunctival hemorrhages. Patient was icteric, the splenomegaly. Patient had altered mental status with the Glasgow Coma scale of 7. There was anemia, normal WBC counts. Bilirubin was raised. Transaminases were raised, but not all that high. There was thrombocytopenia, elevated creatinine, hypoglycemia, coagulation tests were normal. So in this situation, basically the definition of severe malaria is met in the sense there is altered sensorium, there is anemia, jaundice, renal failure, hypoglycemia. These are the other criteria, but many of these were not present in the case which I did mention to you. But presence of any one of these is enough to make a diagnosis of severe malaria in a patient who is confirmed to have falciparum infection. There are some specific issues that I will discuss in the next 15 minutes. The first is how do we confirm the diagnosis of malaria. Next, which is the anti-malarial drug or drugs of choice. What are the complications to look for? What is the supportive therapy and what's the prognosis in these patients? So the first question, how do we confirm the diagnosis of malaria? The gold standard over the years has been light microscopy. So you make a peripheral smear, typically a thick smear and a thin smear. And what are the advantages? It takes 30 to 60 minutes to make a diagnosis, a good peripheral smear examination. Other advantages which are probably more important than just making a diagnosis, it can estimate the parasite load. For example, if you have a smear where the lab says that 30% of RBCs are infected with Plasmodium falciparum, then regardless of whether you give anti-malarial drugs or not, the infected cells are going to lyse. So if 30% of the red cells are going to lyse, that's a lot of hemoglobinuria which the patient is going to have. The hemoglobin is going to drop significantly, high risk of getting renal failure due to hemoglobinuria. On the other hand, if the parasitemia is 1%, then it's okay, this patient may get away without transfusion, the risk of renal failure is much less. So it's important to know the parasite load. It can identify the species. For example, it helps you differentiate between vivax and falciparum. Also, if the patient has already received some anti-malarial before getting organ dysfunction and coming to the ICU, the gametocytes may still persist in the circulation for up to 2 weeks, whereas the actual trophozoites may disappear, and many of the other tests which you do only look for the trophozoites. The other tests which are now commonly used are rapid diagnostic tests, and what I would like you to see here is that the light microscopy requires 50 parasites per microliter to make a diagnosis, whereas the rapid diagnostic tests, the dipstick tests, require more than 100 parasites per microliter. So therefore, they need more parasitemia in order to become positive, whereas a smear may be positive even if there is lesser degree. So a negative dipstick test doesn't automatically exclude, it just means that the parasitemia may be low grade. One important question when it comes to diagnosis is, does vivax infection also cause severe malaria? The question which you really need to ask yourself is, are we missing falciparum co-infection? A good number of patients have Plasmodium vivax as co-infection. So you have a dual infection. So we don't just attribute it to vivax. Maybe we are missing the falciparum. Again, goes to the diagnostic specificity, the sensitivities of the test. Smear can detect 50 parasites per microliter. Dipsticks can detect more than 100. So if you really want to say that this is vivax only and not falciparum, what you need to do is a PCR which detects even 5 parasites per microliter, and this is not something which is routinely commercially available. And therefore this doubt always remains whether your patient also has falciparum co-infection. There's a small series of patients, I think 14 patients reported by Dr. Kochar from Bikaner, where the samples were actually sent to the CDC in the US, where they did a PCR and found that they were negative for falciparum. So there are these 14 cases, largest series from India of confirmed vivax only, which also had organ dysfunction and severe malaria. The difference being that none of these patients had cerebral malaria. So if you have vivax causing severe infection, it probably causes other manifestations, but not as much of seizures and altered consciousness. Our own experience is not with vivax infection, but with mixed infection. So we studied almost 460 patients and found that if only falciparum was present, the mortality was 15%. But if falciparum plus vivax was present, then the mortality increased to close to 40%. So the presence of vivax in patients with falciparum malaria seems to significantly alter the prognosis, and these are patients who probably will require much more intensive care. Next question, which anti-malarial drugs do we use? The 2010 guidelines of the WHO for treatment of uncomplicated falciparum malaria. Okay, what do they say? That the treatment of choice is a combination of 2 or more anti-malarial medicines with different mechanisms of action. So they recommend ACT or artemisinin combination therapy for the treatment of uncomplicated falciparum malaria. These drugs have to be given for 3 days. Okay, these are the various recommendations, and the choice of ACT differs from country to country. Okay, it says artemisinin derivatives should not be used as monotherapy. What they are really concerned about is resistance to artemisinin when they are used as single drugs. This has bearing on the treatment of severe complicated malaria. The reason for recommending combinations is because if you use multi-drug therapy, there is a very low chance of developing resistance to artemisinin. Okay, artemisinins are very rapidly malaricidal, and in one life cycle, that means in 48 hours, you get a very significant reduction. That means 10 raised to 4-fold reduction in parasitemia. Okay, another advantage of artemisinin is they also act on the gametocytes, so that even though the gametocytes may persist, this patient now soon becomes non-infective and is no longer a reservoir of infection for others. These are the various combinations which are proven to be effective. Can ACTs be used in pregnancy? In the first trimester, they are not recommended. The WHO says in second and third trimester it is safe. So if you have to treat malaria in the first trimester, the drug of choice is quinine along with clindamycin. Now coming to treatment of severe malaria. Are artemisinin derivatives superior to quinine? That's the basic question which is being asked. Okay, there is this one study which is called a SEQUOMAT study done in Southeast Asia comparing quinine with artesunate. Countries where patients were recruited: Bangladesh, Myanmar, India, specifically Orissa and Indonesia. Okay, so roughly 730 patients in both groups. There were 13.5% children, 17.5% were pregnant women. Okay, and this is the dose. Remember, the dose is important. It's 2.4 milligrams per kg at 0, 12, 24 hours, and then subsequently every 24 hours. Quinine dose was a loading dose of 20 mg per kg followed by 10 mg per kg 8 hourly for 7 days. What did they find? The results were slightly different in adults and children. In adults, the mortality in quinine group was 24%, which decreased to 16% with artesunate. Okay, so a statistically significant reduction in mortality. In children, it was 11% and 5%, but because I think the numbers were small, this did not reach statistical significance. It's important to look at this part. This is subgroup analysis by the country of origin. We all know that quinine resistance is extremely high in many of the Southeast Asian countries. For example, in Thailand, quinine resistance is to the extent of 70 to 80%. As you come westwards towards India, the resistance progressively becomes less, right? So, is it okay to compare patients with Myanmar and Indonesia with patients in India? If you look at the mortality, it came down from 18% with quinine to 11% in Myanmar, from 12 to 6 in Indonesia. In India, it's 26% versus 21%, and this was not significant. The p-value is 0.5. So, if we try to look at this subgroup a little closely, maybe in India quinine still works, and if it works, then there is no evidence to suggest it's better than artesunate. Okay, but if we look at the whole group, then artesunate does cause a 30% reduction in mortality. That's something to keep in mind. What does the WHO say? It says artesunate is the treatment of choice for severe falciparum malaria. It's based on that Sequomat trial plus a few other smaller trials which showed similar or conflicting results, but the overall net effect was beneficial. Okay, and it does not change the neurological sequelae. That's the bottom line. How do we actually do it? We give anti-malarials parenterally for a minimum of 24 hours. Okay, this is irrespective of whether the patient can tolerate oral medications. Thereafter, the complete course can be given as a combination. So you start off with IV artesunate for 24 hours, 0, 12, 24. After that, if patient cannot take orally, you continue IV every 24 hours. The moment the patient can start orally, you switch over to the ACT combinations. Okay, so typically what you would use is artesunate plus artemether plus lumefantrine, one tablet twice a day for 3 days. So that would be the switch over to the oral therapy. In case you do not switch, then it's important to add doxycycline along with the artesunate to give you a combination. When you are using quinine, the concerns are mainly the side effects. Okay, so it has to be given IV, it has to be given as an infusion over 4 hours and not as a bolus. What we are concerned is that it should be avoided in patients with heart disease. So patients with previous MI, coronary artery disease or conduction blocks, we should avoid it. You should monitor blood glucose because giving quinine increases the risk of the patient getting hypoglycemia. It's very important to realize if a patient of malaria gets seizures, before you say that this is because of cerebral malaria, you must do the blood glucose and confirm that it is not hypoglycemia. And if the patient is getting quinine, then the risk of actually getting hypoglycemia is that much more. The other things you look for is every day ask the patient whether he is having tinnitus or visual blurring, and we do an ECG every day. In 257 patients that we treated, 63 developed toxicity, most commonly day 3, day 4. Okay, and tinnitus was the commonest. ECG changes in the form of QT prolongation was seen in 23 patients, and 3 patients actually developed QT prolongation resulting in torsade or ventricular tachycardia. Doxycycline can be followed up in patients receiving either quinine or artesunate, but they should not be given in children less than 8 and in pregnant women. So what is the drug to be given in pregnant women along with either quinine or artesunate? The drug is clindamycin as advised by the WHO. Next, coming to the complications of severe malaria, the picture on the left is of a patient with ARDS. The picture on the right, anybody would like to guess what this is? Yeah, so this is a patient who had splenomegaly thrombocytopenia and complained of tenderness in the left hypochondrium. So that's a partial rupture of the spleen which could occur in some patients. It's extremely rare. I have seen this happening in only 2 patients, having treated almost like 120, 150 patients every year. So what are the complications? The definition itself lists all the known complications, and presence of any of these is to be looked for. In a series of 301 patients that we studied, hematological complications were the commonest. Platelet transfusion or thrombocytopenia was seen in 133 patients, but only 44 required platelet transfusions. So the presence of thrombocytopenia, even if the counts were say 30,000, is not an indication for giving platelets unless the patient is bleeding or the counts actually drop below 20 or maybe 15,000. However, almost 70% of patients do require blood transfusion, and the threshold that we follow is for patients with organ dysfunction levels below 7, and for patients who are not having organ dysfunction, the WHO says if it's below 5. Renal failure is common, but dialysis is not required by most patients. Patients with hepatic dysfunction have a reasonably good prognosis unless the enzymes are elevated more than thrice. And ARDS is typically seen late in the course of the disease. While all the other organ dysfunctions are seen at the time of admission, ARDS usually occurs when other organ dysfunction are recovering. So you see it around day 3, day 4. I'll just skip these for lack of time. Yeah. Other observation that we had was that while in survivors the organ dysfunction progressively improves, in patients who are not going to survive, the organ dysfunction improves to a point and then starts worsening again. So we looked at why this was happening, and most likely it was because of coexisting bacterial sepsis. In literature, 80 to 50% of patients with severe malaria have bacterial sepsis. Mechanisms: one is malaria-induced immune suppression, sequestration of parasites in the gut vessels causing ischemia, translocation and bacteremia, and the third is patients with ARDS then getting VAP and bacteremia. We found that almost 13% of our patients had bacterial sepsis with positive blood cultures. Okay, and the mortality was extremely high in these patients. This occurred in two phases. One is patients who came with malaria and shock. We now tend to start antibiotics in these patients right on admission because they are having bacteremia in the initial few days itself. And the others are patients who develop ARDS who may then go on to get VAP. So it's important to look for bacteremia and bacterial sepsis. Of all the malarial deaths in our series, almost half of them were due to sepsis. Last issue: what's the role of exchange transfusion? Exchange transfusion is recommended if the parasitemia is more than 10%. That's because if it's less than 10%, mortality is 10 to 25%. If it's more than 10%, the mortality goes up to 50%. These are the various mechanisms which may help which may be helped by exchange transfusion. But there is this one meta-analysis of several small studies, and here you can see that this particular diamond shape here exactly overlaps the value 1, which shows that when you put all the evidence together, there is nothing to suggest that exchange transfusion actually helps. Lastly, what's the prognosis in severe malaria? It depends on which organ is affected. If you have ARDS or shock lasting more than 24 hours, then the mortality is extremely high. Overall mortality in our series was 24%. Depends on the number of organs affected. Needless to say, as the number of organs affected goes up, mortality increases. And one interesting observation was what's the prognosis in patients with HIV who develop severe malaria. So in this study, we found that the deaths were more or less, the mortality was more or less the same. Okay, so all the other manifestations were the same. So HIV does not result in more severe malaria. However, the recurrence of malaria in the following 1 year. Okay, so 50% of survivors had recurrence of malaria requiring ICU admission, whereas none of the controls without HIV infection. So maybe it prevents them from developing long-term immune response, but for the acute episode itself, the outcome is the same. Thank you.